everyone, this is Amanda Moore from the Angelman Syndrome Foundation, and you're listening to the ASF podcast, the show that explains everything you want to know about Angelman Syndrome. We're so excited you're here, and we hope you enjoy the show.
For this week's podcast, we're sharing a session from the 2024 ASF Family Conference. We hope you find this information helpful and enjoy the listen.
Good morning, everyone. We are about to get started here. I have the honor of introducing our speaker for our Food is Medicine session this morning, Heidi Pfeiffer. Everyone, my name is Leah Perryman. I am a member of the board of directors here with the Angelman Syndrome Foundation, mom to Mira, who is 6 with UPD. I actually just this morning had an incredible conversation about how beneficial food and diet can be for our children, how it can control so much of the symptoms that we manage each and every day. Heidi here is a wealth of knowledge and an expert in our community, helping develop the low glycemic index treatment, which so many of our children are able to utilize to help manage constipation, seizures, you name it. With that, I am so pleased to introduce her. If we can give a round of applause for Heidi Pfeiffer and have her come on up.
Hi, everybody. Good morning. Thank you for coming this morning, and I'm honored to be here and talking to you about food, and obviously that's my passion, so hopefully I can convey a little bit of that passion to you as well. But I also want to thank all the board of the Angelman Syndrome Foundation for putting this fabulous conference together year after year, and their energy and enthusiasm to put this all to fruition is amazing. And I have a friend too that's going to help. All right, so let's get started. So today I'm going to do a little bit about history of diet, a little science, and then of course dietary therapy with a little help. There we go. Okay. So looking at this image, I want you to think, what does this image conjure up for you? Is it, nurturing? Is it providing sustenance? Or if you're a foodie, are you thinking, what can I make with this? And is it, can I make a great caprese salad as it's summertime and a little olive oil and some basil and we're good to go? And of course, some mozzarella cheese, kind of dietary therapy compatible. Or are you thinking that it's more of a therapeutic treatment option? And so I'm thinking more along the lines as the father of modern medicine, Hippocrates, thinking about it more of that he did, and that food is, let food be thy medicine and medicine be thy food. And so going throughout time, I like to go back through the history because we also learn a lot from history and how that develops what we are doing today and changing and always making better and improving. But looking back, of course, the cavemen are the originators of the paleo diet, but it wasn't until Hippocrates looking at the purification of the body through diet. And so we know diet changes throughout time, and there are commonalities that we've seen in all the history that's been reported, especially in the treatment of epilepsy. And so one of those things is the correlation between the gut and the brain. And now we're thinking about it as that gut-brain axis. And so throughout time, we've seen that they used to think that it was an intoxication of the intestines that would result in epilepsy. And so they thought, okay, can we put the intestines to rest and purify them and treat the epilepsy? And so over time, that was kind of the thought process. And they've, thought in the 13th century BC, they said, oh, okay, it's diet. Diet takes a huge role in the treatment of epilepsy. But over time, then they said, oh, well, it's fat. Fat plays a really big role in the treatment of epilepsy. It wasn't until it was reported in the 1920s, reported in the American Medical Association journal, that fasting was used as a treatment for epilepsy. And they would use fasting with water only for 30 days. I don't know about you, but lunchtime's coming up. I need to have that lunch. But so how can we also think about what's going on in our bodies and say, okay, what's going on and how can we make this a little bit more doable by providing food and having those same results as fasting? And so the doctors at in the 1920s also came up with that. It was a pediatrician by the name of Dr. Talbot at MGH that said, okay, how can we emulate this with food? And a protocol that's used somewhat today, but also modified over time. And so making it a little bit more doable. And so that's kind of the new theme also of how can we get these same results with seizure control, but also making the diet a little bit more doable and palatable. And so in the 1970s, the MCT oil diet was developed to provide about 60% of the calories coming from medium chain triglycerides. This allowed for a higher amount of carbohydrates, but also 60% from MCT oil. If anybody has tried a lot of MCT oil at once, you'll know that it also has a little gastric disruptive effect. So again, not something that kind of kept going on at that amount, but still people are using it, and it's a great adjunct to a lot of therapies. A lot of newer medications were out at that time, and so diet kind of fell out of favor and not being utilized as much. And then any of you who are probably around my age might know Jim Abrams and the film producer of Airplane and the Naked Gun series. You can nod if that's if you know these. But he had a child named Charlie, and Charlie developed seizures, and Charlie's seizures were intractable to every medication that he tried, as well as surgery. And so he became the parent that did the research, and he went to medical library and came across the ketogenic diet as a treatment option, and then became the angry parent, saying, why isn't this treatment option offered more? And so he went to Hopkins, started the ketogenic diet, and Charlie became seizure-free. In later years, seizure-free, med-free, and diet-free, and is now a teacher in a preschool, living his best life. So it became Jim's plight in life to make the diet more available to everybody who's seeking diet as a treatment. And he's probably why I'm here today too, and using the diet after 25 years. So also in that same theme of trying to make it a little bit more doable and palatable, we know there's the classic ketogenic diet, but we tried to also, in 2002, I developed the low glycemic index treatment in order to also make it less restrictive, but still have the same efficacy. Around that time, the modified Atkins diet was also developed, and in that same theme of making it a little bit more palatable and doable for families. Over time, we've also developed a consensus statement of how the diet should be provided and when it should be provided, to also provide guidelines for physicians as well as then families. And then in 2012, the first series on low glycemic index treatment used in Angelman syndrome. So that's the history of all of it. But thinking about what is a medical ketogenic therapy? And it's any changes that are in nutrition, that in intake, that results in altering your body's fuel source from using carbohydrates as its energy source to using fats. And so primarily, if we have carbohydrates, that's what our body's gonna use. Even if you're on a higher fat diet, but those carbohydrates come in, it's gonna revert back to that. So I also kind of equate that as like a hybrid car. You can use both fuel sources, and whichever one's available, that might be which way you go, but also it's always gonna revert back to the preferential primary fuel source. And so thinking about also what is going on behind the scenes. Confusing slides, lots going on here, but thinking about what's going on metabolically and what's changing in the body, and when you start a ketogenic diet. And so, yeah, looks like a subway map, but what we're seeing here, just to describe what's going on, is that when you start a ketogenic diet, we see that the fat is, the carbohydrates we're using up all of our glycogen stores that are in the liver. Our blood glucose is going down, our ketones are going up, free fatty acids are going up, and it's switching over from using the carbohydrates to using those fats and breaking those fats down. And when those fats are being broken down, they're breaking down into ketone bodies. And those ketone bodies can be found in your breath. So some people describe on a fruity breath. I think it smells more like nail polish remover, and because it's acetone, that's what we can also measure on breath. And there are ketone meters that you can ketone breath meters, and that's what they're measuring. And then there's these acetoacetate. So this is what can also be found in the urine and can be measured on urine dipsticks to see how far in ketosis you are. And then there's the beta-hydroxybutyrate. And the beta-hydroxybutyrate is the blood ketone levels. That's what's being monitored. We also know that the beta-hydroxybutyrate is associated with activating genes that can improve mitochondrial function, as well as decrease oxidative stress in the system. So looking at medical ketogenic therapy versus everyday keto. And I'm sure you've heard, oh, I've been on keto, and everybody that's, especially with it being so readily available, there's so many products out there. But there is a really big difference between a medical ketogenic diet and everyday ketogenic diet, or what I also refer to as a recreational ketogenic diet. With recreational ketogenic diet, if you have a cheat day, no big deal. You might not lose as much weight. You might not feel as good. But thinking about it as in the medical term, having that cheat day could mean increase in seizures, could mean a lot harder to get back into ketosis or get back into on track. And so we really recommend not having any cheat days. And the way I also think about it is if we equate it to medication, having that cheat day from the diet, would you have a cheat day and not take your medicine? So thinking about it more in the medical terms, looking at it that way. We know that, the diet has now been in clinical practice for over 100 years. To me, that's pretty amazing. 100 years, we still don't know how it works, what the mechanism of action is, but we know that it's an effective treatment. We know that a third of the patients that go on a ketogenic diet have greater than 90% reduction. A third have 50 to 90% reduction, and a third have less than 50% reduction in their seizure control. So, and that's in the broad epilepsy realm. We know also now, as we're studying it more, that in certain syndromes and disease states, those numbers are different. And we know, especially in Angelman syndrome, that those efficacy rates are even higher with dietary therapy. And so one of the things that's also important is the ketogenic diet isn't for everybody, and there are certain terms that it's contraindicated and shouldn't be used in. And so just making sure you're working with your team to make sure that your child or angel doesn't have any of these other comorbidities, as we know that 5% of angels have multiple diagnoses. So what is a classic ketogenic diet? And so classic ketogenic diets are based on ratios and amounts of fat, and those ratios are the amount of grams of fat to protein and carbohydrates combined. And when we think about those ratios, they go from low to high, 1-to-1 or a 4-to-1 ratio. All the meals on a ketogenic diet are weighed and measured to the 10th of the gram, and you're following meal plans, kind of like recipes, but it's very structured. And I'm more of a visual learner, so I always like to look at pictures and see what that means. And Charlie Foundation does a great job with this picture. And looking at the same amount of calories from a 4-to-1 ratio and a 1-to-1 down to a 1-to-1 ratio. And what you can see here is that at a 4-to-1, the portion sizes are a lot smaller. And the reason behind this is because fat has more than double the caloric density of a protein and a carbohydrate. So 9 calories per gram for fat and 4 calories per gram of a protein or carbohydrate. And so comparing that ratio, comparing it back to a medication, typically, you start low dose medication and ramp up to see how much you need and individualize it. Same thing with diet. You can start at a lower ratio and increase it up to where you need it. Because as with medications, higher doses also equated with higher side effects. Same thing with diet, higher ratio, higher side effects. And so what does a meal look like? I don't know what your breakfast looked like. I wish I had this one. But it's because the portion sizes, again, are small, it's less than an egg, a quarter of an avocado, some blueberries, about 3 almonds, about 1 ounce to 2 ounces of heavy cream to balance it out. So you're always getting that protein, fat, and carbohydrates in a balance. And so knowing that not everybody can tolerate the restrictiveness of a classic ketogenic diet, developing the low glycemic index diet based on the themes of what I learned from the ketogenic diet. So what did we see with the ketogenic diet was we saw that their blood glucose levels are really stable. So again, going back to that subway and that graph, one of the things that we saw was that those blood sugars, once you switched over, really stabilized out. So you didn't have those peaks and valleys. And so thinking from a nutrition standpoint, there are different foods that impact your glycemic control. And so different foods, even, we know sugar, that spikes your blood sugar. Even different foods spike it differently. And so looking at the different things at what is the glycemic index of food, and in the 1980s, Dr. Jenkins noticed that it wasn't just the quantity of carbohydrates that impact your blood sugars, but the types of carbohydrates as well. So those foods that have a higher glycemic index, meaning that they raise your blood sugar higher, versus those that have a low glycemic index and don't raise it as much. So, and there are different things that can impact the glycemic index of a food. So the fiber content of it, whether it's balanced with a protein or a fat, that all affects how high it raises your blood sugar. So the low glycemic index treatment focused on not foods that don't raise it as high. Again, also though limiting the amount of carbohydrates that you're taking in. And so limiting carbohydrates to about 40 to 60 grams per day. And the reason behind that goal is because your body transitions over to using your fat as your fuel source at about 50 grams. And so that's where that goal was developed from. And so we're going to also balance all those meals with the protein and the fat to continue to keep that glycemic index low. And all those carbohydrates should be from low carbohydrate sources, so a glycemic index of less than 50. But because we're reducing the carbohydrates still significantly, that's a great source of vitamins and minerals. And so we need to make sure that we're adding those back into the diet. And so adding in a vitamin or a mineral supplement to make sure we don't develop any deficiencies. And MCT oil can also be added to this as part of the therapy and part of the fats that are used. And so again, kind of looking at the distribution of calories from a low glycemic index treatment, it's about 60% calories from fat, so equating it to like that 1-to-1 ratio that we saw earlier. About 10% of the calories coming from carbohydrates and the rest from protein. And so in 2005, we published our first article on using the low glycemic index treatment in epilepsy. And looking at it was a small sample size of only 20 patients, but one of the most important pieces we saw that of those, 50% had greater than 90% reduction, so a good efficacy. But really the most important part that we found was that it wasn't the seizures did not correlate with the ketones. And so it used to be thought the higher the ketones, the better the seizure control. But this kind of disproved that because we had ketone levels of like 0.1 or less than what we would consider therapeutic and still having the seizure control. So thinking what else is going on? And then looking also at a couple of years later in 2012, we did the first prospective article looking at Angelman syndrome with it. Based also, we had one patient that I treated that was on a classic ketogenic diet, but could also have some carbs in it that, we were surprised that didn't have any seizures with those carbs. So what's going on here and trying to figure that out. And so when we looked at in Angelman syndrome, we saw that out of the cohort, we had 11 patients that were enrolled in it, 7 of which completed the 4-month trial. And of those, we saw that actually 2 had received G-tube, so low glycemic wasn't an option. One we saw that had Rett syndrome versus Angelman syndrome, so she was taken out of the numbers. But really one of the most important things that we found, that he didn't have any side effects from dietary therapy, but really more importantly, efficacy-wise, 2/3 had greater than 90% reduction in their seizures. And of that, also 80% had an improved EEG. So that's a really big piece. And so a couple years following that, we did another look at a bigger population, larger sample size of patients. And we looked at some other things, and we saw that, of the 23 patients that we treated, we also broke it down whether they had the type of Angelman syndrome, and we found that, we know that 90% of of patients with deletion positive tend to have seizures. So that's why they had a higher percentage in the cohort that we looked at. But we saw that 22% were able to maintain complete seizure freedom, and 43% had maintained seizure freedom except in status or in setting of illness. We had 33% had a reduction in their seizure frequency as well. And again, we saw that the ketone levels didn't correlate with their seizure control. So, meaning that we don't think that's the mechanism of action. So what else is going on? And so looking at kind of an interesting piece that we looked at in this study, part of the study, was that what were their carbohydrate intakes prior to starting dietary treatment? And we saw that they were already at 42% of carbohydrates, so a little bit less than a typical, but there was a reduction of 30% when they went from pre-diet to low glycemic index treatment.
Hey guys, it's Amanda here. As you know, we're here for you, our community. If you have questions about any topics we can discuss in our podcast, or if you have ideas for future episodes, we'd love to hear from you. All you need to do is email me at dearamanda@angelman.org. Thank you so much for listening and your continued support of the Angelman Syndrome Foundation.
And so comparing a classic ketogenic diet, a low glycemic index treatment, and then the American diet. An American diet typically has about 50 to 60% of the calories coming from carbohydrates. And so when we think about, the last slide, and we're only at 40%, it would be interesting to think about that same study today, and because we know a lot of families start to just reduce carbohydrates on their own. So would that baseline carbohydrate be a lot different and a lot lower today if we did it again? So looking at what a low glycemic index treatment diet would look like for a day, you can make it as complicated and fancy or as simple as possible. Almond flour pancakes, you may have come across recipes called chaffles, which is a simple waffle made out of eggs, cheese, and there's a whole slew of different, you can make it savory, you can make it sweet. You can freeze these ahead of time to make it same thing with the pancakes. But it's really distributing the carbohydrates in about 10 to 15 grams of carbohydrates per meal and about 5 per snack. And so, dinner can be, salmon with a creamy dill sauce, or it can be as simple as yes, my son sent this to me through TikTok. It was just simple, taking shredded mozzarella cheese, putting in a nonstick pan, melting it, and putting some pepperoni in there, and that is a low glycemic index 5-minute meal if you need to, and if you want to add some tomato sauce to that as well. And so, again, with the diet popularity of the ketogenic diet, there are a lot more products that are out there, and some you'll read have keto certified on it. I know who's certifying these. It's the Paleo Foundation. They're making money off of it, but that doesn't mean they're medically keto. So something just to kind of keep in mind too when you're looking at those. And so they go by a little different rules than I play by. These are products that I found that are diet compatible, and things that I look at when I look at diet compatibility is kind of as pure as you can get and trying to limit the amount of ingredients that are in there. And again, higher fat, lower, a lot of those keto products will be low carb, but they don't have any fat in it. So I don't really know what makes it low carb, but it's not really keto per se. One of my favorites of these is the crepinis. It's just made literally of egg and cauliflower powder and I think salt, but it's like a crepe, and you can add things into that. You can do it savory again or sweet. So adding in some cheddar cheese and throwing that in the microwave, adding some arugula for crunch, or lettuce or something crunchy that your child likes, and then rolling that up, or doing more of that more of that sweet, and putting nut butters or almost like a nut butter, or nut butter mixed with cocoa powder, kind of like almost like a Nutella crepe. And then, of course, whipped cream. You can always put whipped cream on a crepe. So sweeteners, not all of them are created equal, and yes, that's a play on words. So just because it's sugar-free doesn't mean that it's carbohydrate-free, and a lot of these artificial sweeteners do have fillers in them, and so keeping that in mind when looking at them. So one or two sweeteners that I do like are monk fruit as well as stevia. And so monk fruit, as long as it's the pure monk fruit, there's a brand out there that is very readily available called Lakanto, and they have erythritol added to that. So I try to stay away from that one. We know that also these sweeteners and these additives like erythritol, which is a lot of the sugar alcohols, can also impact the gut biome negatively. And there's a lot of kind of conflicting data out there. So it's one of those things that, you know, if I'm not going to give it to my kids, I'm not going to recommend it for yours. And because, you know, we also know, circling back to kind of what we talked about in the beginning, and that whole gut-brain axis and looking at how it impacts the gut. And if it has could have a negative impact on the gut biome, again, could that be playing into efficacy overall too? So staying away from anything that has all those artificial sweeteners in it. So creativity of families never ceases to amaze me. This is a mom that helps the Charlie Foundation, and she comes up with some amazing recipes out there: pumpkin pie, chicken with broccoli and cream sauce, breads, jalapeno poppers, avocado ice cream. So there are a ton of recipes online, but not of them are all medically keto. So something just to look at, see what it meets, and always talking to your dietitian to see how it can be worked into your child's diet. So again, the diet, because it's reducing carbohydrates so significantly, we need to make sure we're supplementing to meet those needs for vitamins and minerals. And so a complete multivitamin is recommended, as well as a calcium supplement to meet the individual's needs. Carnitine is a protein, and its role is to move long-chain fats into the mitochondria to be used for energy. And we know as we increase the fat content of the diet, we use up a lot more of the carnitine, so you can become deficient. So something that monitoring on a regular basis too with blood levels. Because during that transition over from carbohydrates to fats, we're also throwing off the body's acid-base balance. And so sometimes we need to, and they become acidotic, so we need to put them back into balance, and that's where potassium citrate or buffering agent comes into play. And probiotics, again, going right back into that gut health piece. And, you know, we can take them through supplements, but we can also find them through food. And we know, you know, food is obviously more bioavailable, and so preferentially, but we know that the diet doesn't always meet all the needs. So adequate hydration, huge piece, because it also impacts the GI piece. Finding ways to get it into them, not always easy. You know, simple ideas of like putting a little lemon drops or giving it a taste, but also if your child's, you know, more of an oral child, and a wet washcloth, you can keep that water going into them also little by little. So monitoring, I think about it like pieces of a puzzle. We're always looking at all the different pieces to see what's impacting what. Definitely growth. We have seen on a higher ketogenic diet, sometimes the growth can be impaired. We want to look at their efficacy of seizure control, obviously, and then side effects and minimizing any side effects that are occurring. And then a way to do that also is lab monitoring. And so listing side effects of a classic ketogenic diet, we do see elevated serum lipid levels, in which they think that it goes up in the first 6 months, but then comes back down, but something that we also keep an eye on. Constipation, the number one side effect of dietary therapy. Part of that is fluids, if we're not meeting fluid needs, but also we know that fat can slow down gastric emptying. And so again, if it's a one-way track, and if it's not going out, we're increasing the risk of reflux as well. So deficiencies in water-soluble vitamins, we know that in the first 12 months, 6 to 12 months, selenium decreases, and at about 12 months, magnesium levels decrease. So keeping an eye on that and making sure the supplements are being taken. Renal stones, historically prior to supplementation with buffering agents like the polycitra or potassium citrate, this was a higher incidence, not as much and as common now. So as I see my time ticking down, I apologize. I'm going to go a little bit faster. Side effects from low glycemic, as you can see, a lot less, but the biggest one still being constipation. So prevalence of GI side effects, we know that in Angelman syndrome, we know that the esophagus and the GI tract, that's a big muscle, and if it's low tone, that also impacts the tone of the GI tract. So keeping that also in mind, and thinking about the biggest GI side effect or biggest GI issues in Angelman syndrome are constipation, reflux, poor feeding, swallowing difficulties, whether it's due to tone or due to pocketing of foods. We know that 1% to 2% chance of cyclical vomiting, and then also eosinophilic esophagitis is a common. And there's going to be a GI talk this afternoon, so I'm going to go through this, but we can also ask questions then. So what is the gut-brain axis? And when we think about it, it's, the GI tract, there's a network of nerves connecting the brain and the gut, and it's sending signals back and forth. And so we know neurotransmitters such as dopamine and serotonin are in the gut, and so we can enable the brain to provide variety of functions, including like regulation of mood and blood flow and bowel movements and nutrient absorption, and as well as immune systems and again the microbiome. And we know that the nervous system also works with the endocrine system, so it also stimulates the communication of hunger, satiety, stress. And so thinking about that again, kind of new meaning to gut reactions, and you have this gut feeling. But what foods can help provide a healthy gut? And so thinking about foods that are high in omega-3 fats, so things like salmon and chia seeds and flax seeds, if those can be incorporated into diet. And then fermented foods, this is sometimes the hard one to get into kids. Kimchi, not a lot of kids like kimchi, I get it. Things like yogurt, also fermented. Pickles are a great source, but also making sure it's not just the jarred pickles, but the ones that have those bacteria in them. And then fiber, because even though you have those probiotics from the fermented foods, you need something to feed them. And so that's where fiber comes in. And so foods that are high in fiber too. And so thinking about bringing, again, history full circle, looking at the gut, again, thinking about the ketogenic diet and how it impacts the gut microbiome, and that's kind of where we're thinking about the mechanisms are lying, and the positive changes that occur in the gut and the metabolites, such as the short-chain fatty acids, which play really an important role and can cause the blood-brain barrier, cross the blood-brain barrier and really impact neuronal function. And so not quite sure if your child can tolerate dietary therapy, even making small changes over time, and whether it's taking out concentrated sweets or increasing the fiber content, or eliminating those higher glycemic foods, eating minimally processed foods, things that have less than 3 ingredients in them, and thinking of what's the take-home message of this. We know dietary therapy can be really efficacious. We know that the choice of which dietary therapy really is individualized. The ketones are not necessarily needed for seizure control, so can you do a lower ratio of a classic ketogenic diet or a low glycemic index treatment, and should be really individualized to each person and what their needs are. And then definitely needing to be monitored for any increased risks. And then again, looking at a picture. And what do you see when you look at this picture? And so I see the perfect ketogenic food. It's a 4-to-1 ratio. It's high in fiber, high in fat, great things. Or you can, if you have a comedic side, it looks like it's winking at you with the pit. So with that, I thank you. And any questions?
Studies say that, some neurodiverse studies say that casein can be, not detrimental, but not great for the developing cognition in the brain. So, we're trying to do low glycemic, dairy-free. It's really hard. I think she'd eat a lot more if we could go the other way, but we're doing okay, but I'm just wondering what your opinion is on that.
So different schools of thought. One of the things that if your child is sensitive to it, definitely keeping it out. You can also just try it and add it back in, see how they react to it. And then if they have any changes in their development or then you can take it back out. Coconut is probably your best friend. So coconut milk, you can make chia seed pudding from coconut. So not easy, but definitely doable. Probably a lot more doable now than it used to be and you can get a lot of those fats from other sources versus just the cream and the cheese and things like that. Side effects. So psychosocial side effects is thinking about my food doesn't look like your food. And so especially with siblings and sometimes they're done eating and because the portion sizes are smaller, how does that impact them also? And so just that difference. And so that's the non-nutrition piece of it, but like the emotional part, because will they react behaviorally to that too? And have those right when their plate's done and now they see that other food still sitting there on their siblings. So those are the types of things kind of to work through and side effects. So definitely, I am a big advocate for continuing to have family meals together and making as much the same as possible. So even if it's, the meat and the vegetable are the same, the rest of the family having some bread or some sort of other carbohydrates maybe. But even so, if you're having rice, can you make cauliflower rice? So it kind of looks like it, but it's not the same. Sometimes they're smarter and they know the difference. So sometimes it makes it a little bit more difficult, but any strategies like that to make it look as much like everybody else's as possible. Not easy though. Any other questions? Well, thank you very much for coming. Have a great day.
Thanks for listening to the ASF podcast. If you enjoyed this episode and would like to support us, please share it with others, post about it on social media, or leave a rating or review. And please don't forget to subscribe.